Bismillahirrahmanirrahim. Assalamu alaikum. Welcome back. In today's lecture, we will be exploring the fascinating physiological changes that occur in the body during Ramadan fasting. From metabolism shifts to hormonal adaptations, fasting triggers a series of responses that impact energy levels, hydration, and overall health. Understanding these changes can help us maximize the benefits of fasting while staying mindful of our well being. Stay tuned as we break down the science behind Ramadan fasting. As mentioned in the intro, today we shall see the physiological changes in the body during fasting, and then we will see how these changes behave in the patients with liver cirrhosis. In the start of this workshop, I have discussed with you that this workshop has got 5 sections. Today we are in the second section of this workshop, physiological changes during fasting. And as mentioned, these physiological changes can be divided into 3 main components: the metabolic changes, the fluid and electrolyte balance, and hormonal changes. In the metabolic changes, it's a shift from glucose to ketone metabolism and implications of liver functions. We shall see this in our lecture today. Then in the fluid and electrolyte balance, there's a risk of dehydration and electrolyte disturbances, particularly in patients with liver cirrhosis. And the third aspect is the hormonal changes. We'll see there's the impact of fasting on hormone levels, including insulin, glucagon, and cortisol, and how they impact patients with liver cirrhosis. The metabolic changes, as mentioned before, during fasting, the body undergoes significant metabolic changes as we see shift from glucose to ketone metabolism. The ketone metabolism is active and the glucose metabolism is temporarily a bit suppressed. So there's a great shift from the glucose metabolism to the ketone metabolism. This shift can lead to changes in liver function, including increased ketone production and reduced glucose output. The second aspect or component is that of the fluid and electrolyte balance. Fasting can lead to dehydration and electrolyte disturbances, particularly in individuals with liver cirrhosis. The liver plays a critical role in maintaining fluid and electrolyte balance, and impaired liver function can exacerbate these disturbances. The third aspect or component is that of hormonal changes. Fasting can also lead to changes in hormone levels, including insulin, glucagon, and cortisol. These hormonal changes can have significant effects on liver function and glucose metabolism. So, what are these physiological changes during cirrhosis? In a cirrhotic patient, there are physiological changes, and then with patient with those changed physiological mechanisms, when that patient fast during Ramadan, so these changes pose its peculiar challenges. Cirrhosis leads to a cascade of physiological changes affecting multiple organ systems due to progressive fibrosis, vascular remodeling, and hepatocellular dysfunction. These changes are primarily driven by portal hypertension, systemic inflammation, and metabolic derangements. These changes include hemodynamic and cardiovascular changes. Second, renal and fluid homeostasis changes. Third, metabolic and nutritional changes. Fourth, neurological changes. Fifth, immune system changes. Sixth, gastrointestinal changes. Seven, endocrine and hormonal changes. So we will discuss these changes in detail one by one in the same sequence. First, hemodynamic and cardiovascular changes. What are the different hemodynamic and cardiovascular changes during cirrhosis, irrespective of the Ramadan during cirrhosis? These are, there's portal hypertension. It means there's increased intrahepatic resistance and splanchnic vasodilatation. This portal hypertension is the result of increased intrahepatic resistance and splanchnic vasodilatation. There's hyperdynamic circulation, and this is because of increased cardiac output, low systemic vascular resistance, and arterial hypertension. Then there's the cirrhotic cardiomyopathy. There is blunted myocardial contractile response to stress, diastolic dysfunction, and prolonged QT interval. And then there is hepatopulmonary syndrome, that is the pulmonary vasodilatation leading to hypoxemia and apletypnia or orthodeoxia. And then there is portopulmonary hypertension, that is pulmonary arterial hypertension due to increased pulmonary vascular resistance. So the hemodynamic and cardiovascular changes in liver cirrhosis. On the liver side, there's increased intrahepatic resistance, and in the lungs also there is pulmonary arterial hypertension because of the increased pulmonary vascular resistance. This portal hypertension, it is because of two main reasons. One is the splanchnic vasodilatation because of that nitric oxide disbalance, and there's intrahepatic resistance is increased, and this leads to portal hypertension. And then we see the hyperdynamic circulation. This is because of the increased cardiac output, and there is low systemic vascular resistance and arterial hypotension. We do see the cirrhotic cardiomyopathy and the hepatopulmonary syndrome. So all these are the five main changes in the hemodynamics and cardiovascular system which we see in a cirrhotic patient. This is irrespective of the Ramadan in a cirrhotic patients. The second is that of renal and fluid homeostasis changes. What are these? These include sodium and water retention due to increased renin-angiotensin-aldosterone system activation and vasopressin release. Second, there is hyponatremia due to dilutional effect of water retention. Then there is hepatorenal syndrome. There's a risk of that. That is the functional renal failure due to renal vasoconstriction and reduced renal perfusion. And there's impaired acid-base balance because of it, and it leads to increased risk of metabolic acidosis from renal dysfunction. So these are the four main renal and fluid hemostatic changes what we see in a cirrhotic patients. Sodium and water retention, hyponatremia, hepatorenal syndrome, and impaired acid-base balance. Going into somewhat detail of the metabolic and nutritional changes what we see in the cirrhotic patient, these includes glucose metabolism. First, there is insulin resistance, which leads to hepatogenous diabetes. There's decreased gluconeogenesis, leads to hypoglycemia in advanced stages, and there is reduced glycogen storage. So, on the glucose metabolism, we see these three. It has got these three components: insulin resistance, decreased gluconeogenesis, and reduced glycogen storage. Then on the lipid metabolism, we see reduced lipoprotein synthesis, which leads to altered cholesterol metabolism. And on the protein metabolism, there's increased muscle catabolism due to impaired protein synthesis, and it leads to sarcopenia and frailty. And there is micronutrient deficiencies, which specifically are the most common are the deficiency in vitamins A, D, E, K, that is the fat malabsorption, and zinc and magnesium deficiencies, which contribute to hepatic encephalopathy. So on the metabolic and nutritional changes, these has got four important components: the glucose metabolism derangements, lipid metabolism derangements, the protein metabolism derangements, and micronutrient deficiencies. In the glucose metabolism, we see the three main changes: insulin resistance, which leads to hepatogenous diabetes, then the decreased gluconeogenesis, which leads to hypoglycemia in advanced stages, and reduced glycogen storage. And the lipid metabolism, as said, there's reduced lipoprotein synthesis, which leads to altered cholesterol metabolism. And on the protein metabolism side, there's increased muscle catabolism due to impaired protein synthesis because the liver is faulty, so the sarcopenia and frailty. And in the micronutrient deficiencies in vitamin A, D, E, and K, which leads to fat malabsorption, as well as there's zinc and magnesium deficiencies, which contribute to hepatic encephalopathy. What are the neurological changes which we see in cirrhotic patients? There's hepatic encephalopathy. We know that the well-known complication, accumulation of ammonia and neurotoxic substances, which leads to cognitive dysfunction, confusions, and even coma. Then autonomic dysfunction leads to impaired baroreceptor response, leading to orthostatic hypotension. And this becomes problem when the patient is on beta blockers, especially carvedilol, sleep disturbances, and mood disorders due to altered neurotransmitter metabolism and melatonin dysregulation. So in the neurological changes, there are three main: the hepatic encephalopathy, autonomic dysfunction, and sleep disturbances and mood disorders. On the immune system changes, what we see: cirrhotic immune dysfunction syndrome, CIDS. It's a combination of immune deficiency, that is the impaired phagocytosis, complement dysfunction, and systemic inflammation, that is the activation of the monocytes and macrophages. So we see the cirrhotic immune dysfunction syndrome, which has two components. So on one side, there's impaired phagocytosis and complement dysfunction leading to immunodeficiency, and there's systemic inflammation. It is because of the activation of the monocytes and macrophages. So it's an imbalance, or this is a dysfunction syndrome. Second is the increased susceptibility to infections. Spontaneous bacterial peritonitis, pneumonias, UTIs, these are very common in cirrhotic patients, and this is because of this immune system changes. And the third is the endotoxemia and systemic inflammation, and this is because of bacterial translocation from the gut, exacerbating inflammation and multi-organ dysfunction. So these are the three main immune system changes: cirrhotic immune dysfunction, increased susceptibility to infections, and endotoxemia and systemic inflammation. Coming to the sixth are the gastrointestinal changes. What are these? There is esophageal and gastric varices due to increased portal pressure. We see the gastroparesis and delayed gastric emptying, which is because of the autonomic dysfunction affecting mortality. And there's a small intestinal bacterial overgrowth SIBO, which contributes to endotoxemia. And this altered bile acid metabolism leads to fat malabsorption and steatorrhea. So there are four main GI changes: esophageal gastric varices, gastroparesis and delayed gastric emptying, small intestinal bacterial overgrowth, and altered bile acid metabolism. And coming to the seventh one, that is the endocrine and hormonal changes, what we see: hypogonadism. There's a low testosterone in men, and there we see the menstrual irregularities in women. There is adrenal insufficiency due to impaired steroidogenesis, and there is thyroid dysfunction, low T3 syndrome, euthyroid 6 syndrome. This is also seen in cirrhotic patients. So on the uh, endocrine sides, three main changes: the hypogonadism, altered adrenal insufficiency, and thyroid dysfunction. So any cirrhotic patient, depending upon the stage of the cirrhosis, they are having all these seven physiological changes. And when a patient with having these seven physiological changes, that patient fast, definitely that the fasting brings some unique risks and challenges. So in the next section, we shall discuss in the next vlog the risks and complications of fasting in liver cirrhosis, because we understood today that any cirrhotic patients, they do have these physiological changes, at least seven types, and we explain each and every type in detail, what are the subcomponents of those physiological changes. So if a cirrhotic person fast, what these changes bring risk and complication. So regarding next vlog, please share your thoughts, your comments, your queries in the comments section below, and I will try to include those points in my next video. So we continue this discussion, and we are able and we become able to decide properly to our cirrhotic patients based on the concrete data that whether they should fast or not. So till tomorrow, I take permission, I leave you. See you tomorrow. Khuda Hafiz.